We are about to start the Meet the Professor session on pregnancy and diabetes. I request the Professor Seshaiah, Dr. Sunil Gupta, can come down to the stage. Dr. Panir Selvam. No. You are going to give an introduction now. Huh? How is it?
Friends, ladies and gentlemen, I am not going to speak. I am going to only answer questions in case you are raised. Now we got panelists with me. Dr. Sunil Gupta. He is from Nagpur. He has done lots of work in pregnancy diabetes. And we also got Anand Moses and Dr. Panir Sulam. Panir Sulam is a person who has been involved with us in the project called Double Day Project. And he is also knows, we screened about 12,000 pregnant women to know what is happening. Anand Moses, by virtue of his Dr. Moses, he is also imbibed in this subject GDM. Last RSS meeting, we had a nice presentation from that group telling that DIPSI guidelines, better guidelines. So we got enough people here to answer our questions. Dr. Anjalachi is professor of obstetric gynecology from SR Medical College. She is also very much interested in GDM. As a matter of fact, she is the only obstetrician who done PhD in GDM. So that way she is not only obstetrician but also diabetologist. So we have good panelists with us. See, this subject, somehow if we take diabetes, there is no problem with diagnosing diabetes. So simple. Does not change for years and years. Same fasting, either WHO 120 is above, now they brought to 110 and above, ADA 110 and above, 200 and above. There is no confusion at all in the world about the diagnosis of diabetes. Same way, diagnosis of IGT, there is no difference in the opinion anywhere in the world, 140 to 199. The problem comes only in pregnancy. There are a number of changes occurred if we look at the historically. First, O11 and criteria, Mann criteria, different numbers they used. After that, Carpenter-Kushner criteria, again the some numbers they gave. Then NDDG criteria, again some numbers they gave. Then came WHO, their own criteria. Then International Diabetes Pregnancy Group, IADPSG, against criteria. That shows such a amount of confusion in the diagnosis of GDM, not in non-product. Non-product is very simple. So in this confusion, India is trying to make a simple solution for diagnosis GDM. Now we'll discuss about this and as progress now. Now, if you want to ask any doubt, any question, you are welcome to ask, because it's going to be a what do you call one-to-one discussion. So we will not have much slides, only 5 hours slides will present here. Somebody can start the discussion now. Anybody wants to suggest somebody? You come. As Sunil Gupta is going to talk few again more information on this, then you will go on for the slide projection. Please come.
Actually, this particular session, as has been requested by the organizers to us, should be more of a question-answer session and a discussion. Right. And that's why intentionally we have not kept any of the slides. But then just now, half an hour ago, Professor Seshaiah wanted to put forward one more concept of gestational glucose intolerance, or GGI. So before we start, we should first understand what is hyperglycemia in pregnancy, and DIPSI guidelines have been very well laid down, very well accepted. Now it is also with FOXI, and very recently we are fortunate to have Professor Seshaiah, who is also into the core group of WHO committee, and they very recently he informed us that this DIPSI criteria of single test in the non-fasting stage. So any patient coming to you, and irrespective of the term of pregnancy, whether it is first trimester, second trimester, or third trimester, at the first given opportunity, DIPSI recommends that at the first given opportunity, You are supposed to screen the patient by giving 75 gram of glucose irrespective of the time of the meal. And if the 2 hours post-glucose value is above 140, we call it as gestational diabetes, and you may start the treatment. You need not call the patient next day fasting or again subject them to fasting, because they are not very, I feel there is enough discussion and debate already occurred on this aspect, so we are not going to land up in that. We straightway go ahead with the clinical recommendation what DIPSI gives. That's one thing. And once we diagnose gestational diabetes by 2 hour DIPSI criteria, irrespective of time of meal, if it is more than 140, we treat them. Now, our goal in treating pregnancy diabetes is fasting. We should try to achieve 90. And the postprandial 2 hours, you are supposed to achieve as 120. If you are exceeding these goals and you wait for maybe 1 week or 2 weeks, and if the patient does well on diet control alone, just keep on monitoring such patient maybe twice a week or once a week, depending on the patient. It has to be absolutely individualized. Now, we may get a patient who has got at the diagnosis, you have high HbA1c, you have fasting blood glucose, maybe 130, 140, 150, postprandial maybe around 203, 250. That situation, you did not wait for the diet control to appear, rather diet control to achieve a fasting of 90 and postprandial 2 hours of 120. Straightway you can think of starting insulin in these patients. So insulin again becomes a drug of choice. Your target, once you achieve target on a particular given therapy, then also as the pregnancy progresses, the hyperglycemia may further increase, at least till 36, 37 weeks of pregnancy. And that is why we should go on monitoring such patient. And it has been observed that the insulin requirement from the day one of diagnosis till delivery goes up by a 1.5T, almost 2 times till the time of delivery. And that's why you need to go on increasing the dose of insulin. Now, very important clinical guideline from DIPSI as well as most of the people who are working in this field since many years is monitoring of fasting, post-breakfast, post-lunch, as well as post-dinner. Now, different population may behave differently as far as these postprandial hyperglycemic states are concerned. In our population, we find it is the post-dinner which seem to be high. In the population from South India, it seems that it is the post-breakfast which is high, and globally also it is seen. But irrespective, whatever period you have postprandial hyperglycemia, we recommend that you should monitor and accordingly adjust the doses. Now, if your patient is doing well with diet, monitor them. If she is requiring insulin, then you start with insulin. There are different recommendations about insulin, which insulin is to be used. Insulin analog, the rapid acting analog seem to be the best if the patient can afford to go for 3 times a day insulin. But when it becomes a compliance as a big issue and patient cannot take 3 times a day insulin therapy, even mixed variety of insulin like 50-50 or 30-70 can be given. But if the patient does not have fasting hyperglycemia, it is better to avoid long-acting insulin in the night and use rapid-acting analog maybe 3 times a day. Or sometimes, very good discussion we had in the last meeting almost 15 days from now, that you can give mixed variety insulin in the morning and maybe you can use rapid-acting analog in the night. Mix 50-50 in the morning and short-acting in the night so that you avoid fasting hypoglycemia in such individuals. So this is about diet and insulin. These are just carry-home messages. And as I have been assigned to talk 1 or 2, 3 or 4 slides on another untouched variety of diabetes, which you and me come across almost on a regular basis. A patient coming to you who has a bad obstetric history with the GTT you did, and the GTT value comes to 125 or 130 or 135. When you talk about the goal, we say you should try to achieve fasting as 90, 2 hours as 120. Then why should, after patient is being diagnosed, if after meal or after glucose is 130, why it should not be treated? And this was again discussed. And we have a small data on a borderline case of this gestational diabetes, which have been accepted by DIPSI as GGI, glucose intolerance, gestational glucose intolerance, GGI. And these GGI individuals are having post-glucose value between 120 to 140, and they have not crossed the diagnostic value of 140. Whether we should target these individuals. So we have small data, and this is what our group says: that fasting you should try to achieve 90, pre-meal 105, 1 hour 130 to 140, 2 hour less than 120, 2m blood glucose should be 60 to 90. These are your targets. If you have mean blood glucose more than 150, you end up with perinatal mortality of 25%, 100 to 150, 15%, but if you keep mean blood glucose less than 100, mortality is reduced to 4%. And that is why we have studied around 400 pregnancies, and GDM was classified as the previous WHO criteria. And then we have IGGT, or the now name is GGI, gestational glucose intolerance. If 2 hour value is between 120 and 140, and these patients were followed, and if you see their age, weeks of diagnosis, pre-pregnancy BMI, they were not significantly different. One group is GDM, which is around 200, another IGGT or GGI, around 208 patients. And if you see the bed obstetric history here, 45% of the GDM women, around 34%, so almost 1/3 of the group, they had bad obstetric history. And at full term, almost 50% of them, they also require insulin, which is a big number to achieve the target in the follow-up. If you see the fetal loss, which was initially in GDM 45%, after treatment has come down to 4.4%. Here in 34% patient, it has come down to 1.5%. Some of them may argue that it is an over-diagnosis, but in high-risk individuals like this, why should we not approach such diagnostic criteria and treat and keep the follow-up of these individuals? And as we've shown, out of these 400 pregnancies, 200 of them, they may require insulin, a small amount of insulin. So our concluding slide is that we have these individuals which are borderline, and these patients, if you follow them well, and maybe you will be able to reduce these fetal losses, fetal mortality in these individuals. So this is another area where Professor Seshaiah wanted us to concentrate on, and we have some data which was presented across in various conferences. And I feel we should stop here as far as GGI is concerned. So we have got a clear-cut idea. Now we have some scope of discussion on insulin, scope of discussion on oral drugs. I feel there will be some questions on this. And of course, diagnostic criteria, if you want to further clarify, we are there, panel is there to talk on this.
Thank you, Sunil.
Sir.
And now we take on, I think now audience would speak. Now my first question to you all will be, including panelists, why should we screen pregnant women for diabetes? Why should we screen? Open this slide.
Okay, sir. Slide one down.
No, after that. We'll ask a question to you also.
No, question. Why should we, the first question, why should you screen all the women? Maybe you can
Open.
answer. That question very important. Why should we screen all pregnant?
First slide. So these are all the area we would like to cover. Questions to be addressed: why should we screen the pregnant woman for diabetes? What will happen if we don't diagnose and treat? How to screen, when to screen, how to treat, how to follow up. So these are all the area. As a practitioner, all of us.
Keep to yourself first, answer first question.
Yes, sir.
That's all.
Why should we screen the pregnant woman for diabetes? Because totally the disease is silent, all of us are aware. And general diabetes per se, we are not in a position to cover, or the whole population is not in a position to undergo screening. But in diabetes, luckily, Professor Seshaiah had took interest 30 years before, and his interest is persistently there, not only in Chennai and Tamil Nadu, all over India, now globally also his work is getting recognized. So it is better to screen all pregnant women for diabetes, because in our survey, what Professor Seshaiah took, rural area, out of 100 women screened, 10% of them found to have diabetes.
I will
Similarly-
add,
Thank you. Now
I
let
will add
Angela
some more
share.
thing.
All right, madam.
See, all of you know, during pregnancy there are metabolic changes takes place. In the metabolic changes, actually we are all intermittent eating people. We have a fasting state and we have a fed state. So a pregnant mother, she has a fasting state and a fed state. And during fasting fed state, she accumulates all the nutrients to supply to the fetus. Okay, this happens by the process of facilitated anabolism. And during... Point to the question. Yes, sir. So, because of this changes, every woman has, in the beginning of the pregnancy, they have the accelerated insulin sensitivity, and in the later half of the pregnancy, they have hyperinsulinemia and insulin resistance. So, every pregnancy, it occurs. So, we don't know which time they will have this abnormal glucose tolerance. Every pregnancy, whether she is a primary, she is a multi, whether she has a bad obstetric history or not, the metabolic changes takes place and insulin resistance occurs. If this resistance cannot be overcome by her islet cells by increased insulin secretion, then that results in carbohydrate intolerance and the untoward outcome, fetal outcome. So every pregnancy has to be screened, and the screening has to be started early. That's very important.
Now what she wants to say, the diabetes, pregnancy say diabetes stress. Every woman will go through the stage of stress. That is why pregnancy is supposed to be an important cause of diabetogenic stress. So when know that stress, we don't know how to unmask it, how to find it out. The only way will be to screen for every pregnant woman, and it is mandatory now to screen every pregnant woman during pregnancy. Now next question comes, when to screen? It is first trimester, second trimester, third. When would like to screen for the glucose tolerance pregnancy? Now Pannisalam.
Better to screen from the beginning, because as we all know again, asymptomatic nature of the hyperglycemia first. Then second one, the earlier understanding, they were counter hormones, the placental hormones, the human placental lactogen and prolactin, progesterone, all those things. We are under the impression it is getting elevated only in the second trimester or third trimester. At that time only, if at all glucose intolerance is going to happen during pregnancy, if we have to screen during second trimester or third trimester. But in our study recently what we have conducted, many women are developing diabetes in the first trimester itself. Many of them are even before marriage or even before pregnancy found to have hyperglycemic asymptomatically. If you don't diagnose and treat, what will happen? The fetus which is growing in the mother's womb is getting sensitized, or the fetal beta cells are sensitizing the mother's excess glucose. The fetal beta cells are getting blunted during its origin itself. So it is better to identify hyperglycemia in the first trimester itself rather than diagnosing GDM in the second trimester or third trimester.
Now I sum it up. Now all the test books will tell, if you read any test book, screen between the 24th to 28th week. There no book says screen the first trimester. Why should we screen the first trimester? The two reasons. One, there is a chance, as I correctly said, a pre-diabetic, if she didn't know that she is diabetic, she can land up first trimester. And if you don't check the sugar, that means she is going through pregnancy without knowing that she is diabetic. So to know whether she is a type 2 diabetes marching through pregnancy or first time diabetes, only by doing blood test the first trimester is essential. One. Second, we've got a number of people, particularly in our country, Indians are more prone to type diabetes, and nowadays late marriage, so the chance of GDM is more, so we must screen the first trimester. Second physiological reason is when a woman conceives, the fetus pancreas, very important physiological, embryological angle. By 11th week itself, fetal pancreas develops. This pancreas, beta cell of the pancreas or the fetus respond to maternal glucose level by 12 to 16th week of gestation. Once it sensitizes glucose in the mother, it goes on secreting. That is why fetus became macrosomic. So to avoid that, you must screen earlier and control the meal plan or insulin. There are two reasons. One, to know whether she is a pre-diabetic, and second, physiologically, to control her blood sugar in the first trimester. So that is two reasons. That is why if you follow a test book, there is a problem, 24 days. In Indian scenario, you have to screen the first trimester itself. Then, Pandit, what do you think about screening procedure? What do you think is best procedure? What is happening in the world? What are the procedures available? Step by step, either you can answer or Anjalachi can answer the question. Yes.
So, for the diagnosis, we have the various criteria. We have the WHO criteria, where the fasting and post glucose is there, but fasting it is not given concern. Only the post glucose 2 hour value is taken as 140 milligram.
I guess one more confusion. What Anjalachi says is true. Anybody who asks what is the classification of how to diagnose for WHO criteria, they will say fasting 110 and above and 2 hour more than 140. But WHO never says fasting. They always says do the 70 gram glucose, 2 hour PG more than 140 milligram, just like IGT non-pregnant adult. So confusion came because some people misinterpreting saying both fasting and 2 hour PG. So typically, strictly speaking, it's only 2 hour PG because once 2 hour PG more than 140, no woman will have 110 fasting. It will only less than 110. So there's no point in doing fasting blood sugar during pregnancy. Do only one test. That is the reason why we would like to know. WHO has given up fasting. Now it's going to some other way. Now again, Angela, you can.
See, all these criteria, what I am going to tell is on 75 grams GTT. Next is the American Diabetic Association criteria, where the fasting should be less than 95, 1 hour should be less than 180, and 2 hour value should be less than 155. And they say 2 values. Any 2 values met or exceed, you diagnose GDM. That is the ADA criteria. Then you have the IAD PSD criteria. Again, there is the fasting should be less than 92, and 1 hour should be less than 182, and second hour value is 153. So it says any one value if abnormal, you diagnose GDM.
No, it is not
Okay.
that. It is not easy. What says correct? 92, 180, 153. That is brought down to this level. But the catch is, they may say one value is enough to diagnose GDM. But unless you do 3 blood tests, you have to do the fasting 1 hour and 2 hours. Then only you can say pick up one of the value to diagnose GDM. That means you are not getting away from simplicity. There is still the complex problem of ADA, everything, 3 blood tests. That has become very expensive for the countries like India or South Asian countries. None of these countries, the reason is none of the countries have program to diagnose diabetes itself. In our country also there is no program for diabetes screening. Only you may be doing, I may be doing. As our own policy, there is no policy to diagnose diabetes in the population. That being the case, if you are going to ask government, I want to screen for GDM, doing 3 blood tests, which government is going to do that? Do you think that's possible? You respond now. 3 blood tests to do GDM, how many you and me can do, private hospitals, but the government won't do it. So the bargain, nobody will be screened. The one more thing also will complete here. Suppose I follow only fasting. My value will be different. Anjalachi follows only 1 hour. Our product will be different. Sunil follows only 2 hours. Again, because only one test, his product will be different. So again confusion. He will say, no, my product is only 10%. She will say, no, it is 15%. Because each one following different level of blood sugar level. To avoid this only, we have come to different, how to overcome this. So we want to find out a test which is simple, doable, and evidence-based. Now Anand Master will tell what test he has been doing now.
Like what Professor Seshaiah said, universal screening was not possible all these years probably because of the complexity of the test. So as I said, in a clinic you can do a 3-hour GTT or a 2-hour GTT or whatever you want because the number of cases you see may be very less. Whereas people working in government hospitals, where we see hundreds of patients, antenatal clinic, daily antenatal clinic OP attendance runs into 50 to 100 patients every day, where we must have a very simple test to diagnose GDM, which should be validated against any of the known tests. That is the most important thing. We just should not have a test which is not validated. In that way, the new criteria which was proposed by DIPSI was a simple test, very simple test, where irrespective of the meal time, as the person walks into the clinic, you give 75 grams of glucose and check the blood sugar after 2 hours. And this seemed like a very simple test, but there was doubt in many of minds of many people, how will it be equal to the WHO criteria, or will it be equal to the ADA criteria and IADP criteria? All these questions were raised. And in view of this, when I was in Kilpauk Medical College, we did quite a large number of patients study where we compared all the three criteria. And even when we started, even the department, but some of my assistants were little skeptical. They said, sir, it may not, suppose it does not come equal, what to do? Then they said, we'll just go ahead. And to our surprise, we found that DIPSI criteria was equal to, as good as the WHO criteria or the ADA criteria in diagnosing gestational diabetes. And the usefulness of this test is the single step procedure, irrespective of the meal timing. You can screen whether in the first trimester, second trimester, any time, or even 2-3 times for the same patient. And it has, now I think in most of the OPDs, at least in the medical colleges, we have this simple, very simple procedure where as the patient comes, even the doctor is not, the nurse gives the glucose, and at the end of 2 hours, the blood sugar is drawn, and screening is done universally.
Dr. Anjali, will you define what do you mean by the single step procedure? Will you define?
So this single step procedure, when the patient comes into the antenatal clinic, you just give, irrespective of her fed state or she is in the fasting state, you just give 75 gram glucose. And after 2 hours, you estimate the blood sugar. If the blood sugar is 140 and above, you diagnose as GDM. And this very well reflects the fetal outcome, actually.
Okay, you defined very well. Now the question comes. Those who have not listened to me previously may raise a question. Suppose I give a woman, she comes of the breakfast. If I give Sunday glucose, don't you think your blood sugar will go up compared to fasting? How many people think it is possible? I am giving a hypothetical question. Suppose a woman comes to the diabetic clinic, you want to give Sunday glucose test, she comes she has had a breakfast, she came to you, you give 70 gram glucose. Her blood sugar, will it go up more than 140? What is the answer? Well, I will answer the question. See, it is important physiological understanding. Whether is fasting or non-fasting, if a person is going to be a normal, even if it takes 3 idlis, comes to a diabetic clinic, even if he gives 100 gram glucose load, what will happen? She is normal. So insulin cycle comes immediately, her blood sugar will not go up. If she happens to be a GDM, if you are going to give challenge, her sugar will go up. That is simple physiological explanation why new non-fasting cells you can do it. They are fasting, non-fasting, irrespective of last meal timing, you give 70 glucose load, if she is going to be normal glucose tolerant, her blood sugar will not go up. If she is going to GDM, she will definitely throw the blood sugar high. So that is why you can easily find out whether it is going to be GDM or non-GDM with one single test.
Sir, we have some experts in the audience. Dr. P.V. Rao, your comments on this. Can I give a hand mic to, or you can use this mic.
We have taken a clue from Dr.Seshaiah because I have been hearing this for the last several years. And with the idea from Dr.Seshaiah, though we have not discussed with him personally, but our idea about 5 years back was to have a biomarker for identifying gestational diabetes by at least fourth week. So we collaborated with a Finnish group, and they have given us about 90 samples of GDM and 90 samples of non-diabetes pregnancies. Sequentially, they have given us serum samples in first trimester, second trimester, third trimester, and our samples were analyzed between 5th and 12th weeks in first trimester. And then we have looked for fibronectin, glycosylated fibronectin, adiponectin, SHBG, plasma lactogen, CRP, and two more. Right. And ultimately, we have found out that fibronectin as well as glycosylated fibronectin, which are otherwise known to be biomarkers for preeclampsia and early fetal loss. So these are the two directly correlating very well with very good specificity, sensitivity, and our ROC curves are excellent. So ultimately we found out that glycosylated fibronectin done anytime between 5 and 12. So that is the earliest biomarker which we connect. The paper has come in American College of Obstetrics and Gynecology, the Green Journal, the most prestigious journal, and the online is available from August 7th. So the idea has come from you, sir. Though we have not discussed all these things with you, but because we have been listening that we need a single biomarker, and that too as early as possible in pregnancy. And we are sure now we have something to offer to society, and it will be not expensive. So please do not play it down saying that you are bringing out all expensive tests. It should not cost more than 300 or 400 rupees, exactly same as what you spend for a glucose tolerance.
Still, it's costlier than the DIPSI test. So, DIPSI test is going to...
Will you be repeating the test subsequently? So, you said in the 5 and 12 week.
See,
keep on asking.
Rao has come from the high-tech city. No, see, we should not deprive science. It's scientific work, it has to appreciate it. You see, otherwise somebody will tell, I only found out. I am happy that Rao found out and excellent. But let us see how practically used. I am for science. At the same time, we must look for the clinical as well as the epidemiological in the usual population. Now, Bhavadani is reaching to answer some question.
So, I just wanted to know whether you have compared the fasting and the non-fasting in the same manner.
Yes,
Yes,
that is why.
No, it has been.
She has asked a fundamental question again. This last guy, who is Rama's wife? You should not say Parvati. She is telling, okay.
Not that, sir.
I know, you know about that.
Studies,
I understand. This study is actually Anjalakshi was professor of obstetric gynecology in Obstetric Institute. We were discussing about this type, like I discussed with Rao, I was discussing with them also. Why not find a test which is simple and economical and feasible and less stress on the parent woman? Then only this idea was conceived. Then she was doing the test. It was so good. As a matter of fact, if you go for old ADA screening, you give 50 gram glucose. Remember all those things. 50 gram glucose, 2 step, 5 gram glucose, and it tests the blood sugar more than 140 1 hour. It is GDM, no problem. Less than 140, you must do again classical 100 gram GDT. What the explorers stated was 50 gram, non-fasting or fasting. So that gave us a clue. And one more study came, Petit group also. He also found out fasting and non-fasting is going to be same in NGT women, but will be in GDM. So that is how this study was found out, whether in the fasting and non-fasting state. I told you the physiology, what is the basis behind that. If she is going to be diabetic, she will be diabetic whether you give 70 gram, 100 gram. There is no difference between the challenge of glucose. Now, as recently there was published in the journal Endocrinology about from Rajasthan paper, one paper from your group and another Permal group.
Yes.
Recently published. They also found, they compared WHO and IDPG criteria, and they ultimately came out saying that WHO criteria, that's what we have for DIPSI criteria, is equivalent to that of doing 3 blood tests IDPG. So now it has been clear that you can follow only single step procedure of diagnosing. Yes, Ramkumar wants to add something.
Sir, this test is accepted, and to my surprise, one infertility specialist, he is screening and he is writing DIPSI criteria and he is sending me cases. So it's accepted. I think he's saying he had some guidelines from Obstetric Society about DIPSI. I think it is accepted now.
Okay.
Sir, good afternoon, sir. Why there is a deviation from normal diagnosis? Normal diagnosis of fasting, postprandial or random? With low cutoffs, why can't we use that for pregnancy women?
Sir, I will answer, sir. So, as the professor pointed out, see, the normal physiology, as he told, whether you take food or not, if your physiological secretion of insulin is intact, blood sugar will be normal. Why we want to follow this procedure? While we screened in Tiruvallur district primary health center and sub-center, if we ask the pregnant woman to come in empty stomach, out of 100 women, only hardly 20 or 30 people only coming in true fasting. Remaining, they take something and come. it was a great challenge for us also to execute the work. At that time, by discussing all those things, we thought even they have taken whether tiffany or whatever it is, let us do one blood test and give glucose 2 hours after glucose. Same woman, we will strictly ask them to adhere the advice for 3 days. Again you come and Paka fasting. Madam only did the study. So we compared. See the post-glucose with food, post-glucose without food, almost same for normal people. So that only we want to simplify the procedure for community based.
Question was different. Question was different.
My question is, why the pregnant women have a different diagnostic criteria other than normal diabetic people?
Correct.
That's why I told you, the confusion starts from 1800. Carpenter first was O'Sullivan started some confusion. And all the, and if you take in the book, and I'll come back to that. See, even those days, they had a different cutoff point for the pregnancy compared to non-pregnant adult. So the reason was, when they followed up, they found out those people who were going to have this type of glucose level became diabetic in the future. But it's not based on the fetal outcome. Note this. So any criteria must have the fetal outcome. So again, everything went on like that. Now, if you want a non-pregnant adult, same like pregnancy.
Non-pregnant adult have a ADA criteria.
Yes.
With lower.
ADA, what about we are not American?
No, sir. We have a criteria like fasting more than 100, for diagnosing more than 125, PP more than 200, random more than 200.
Yes.
Same criteria with low cutoffs. Why can't you apply to the pregnant woman?
No. See, this one physiology comes here. During pregnancy, fasting blood sugar comes 10% than non-pregnant. If she is a non-adult, 100 milligrams, sugar comes down to 10% during pregnancy. So you'll miss it again. So any woman, suppose I'll give an example. A patient comes to you, husband, wife, they came. You do one blood test in the fasting. You find it 90, 92. If you tell that lady you are GDM, what will happen to you? Or husband, he is asking you are something making wrong diagnosis. Because I know diabetes on 100, how can it call 90 as a GDM? It is a psychological impact on the would-be mother, both husband and wife. That is why we always have a challenge. Never declare your blood sugar 90 in fasting, you are diabetic. Never do that. It's only human, it's happened in Punjab. Number of times what happened in the Punjab, I believe, we tell that woman that, most of the what happened, mother-in-law go with the daughter-in-law. If you tell mother-in-law in front of daughter-in-law, mother-in-law that you are diabetic, GDM, she flares up. The chance is that she may send daughter out. She might take her home back. Why one more burden in the house? So that is why we always challenge. You prove that. Give them glucose. Then you tell it is better 140 and above. 140 is nothing but IGT. What IGT non-glucose, non-pregnant adult is GDM. That's simple, very simple understanding. One need not go into all detail. Just keep one mind. Remember one figure, one test. See, if you ask Anjalachi, she obstetrician, she will not be able to tell now what I am telling. I'm sorry, See, she has got so much of work, infertility, surgery, that why should unnecessarily obstetrician burden with their mind with 92, 180, 153, 195, 180. What is it? What numbers? There's number playing game. No. You just tell them or tell the woman, do the blood test, 140, finished.
See, the values in pregnancy are different because of the changes in the metabolism. There is a metabolic adaptation to give nutrition to the fetus. So, in fasting state, she exhibits features of starvation. Okay. So, and fasting blood sugar is very, very low. So, I had a fasting blood sugar of 40 milligram during my first pregnancy. You believe it or not, I had a GTT. So, that time 40 milligram. I came from my home and all the technicians were looking at me with the 40 milligram blood sugar. Okay. So, it is so low. So, the fasting is low and postprandial increases. So, we have a different criteria for the pregnant women. That's what your question, why we should have a different criteria?
No, madam. We will have a different cutoffs.
Yes.
Compared to the normal.
Yes.
Non-pregnant.
Non-pregnant, yes.
Why to go for challenge, I am asking.
Challenge, unless, see, actually, the
normal postprandial you can.
Excellent. I see. This is what I was looking for, the question. So that's what I'm telling you. If you do normal blood sugar, he was telling you, never exceeds 120. He told us, no, never exceeds fasting may be 80 or 19, 120 never exceeds normal pregnancy. So you can do that. If you do the postprandial with 120 and 130, 125, you must tell that woman, you are slightly above normal, don't tell diabetes. That if you say, Sunil used this very nice word, gestational glucose intolerance. So you're not going to tell the use the word GDM. You can do that. But only thing, if you want a diagnosis, if you want to compare data with all of you, we need some parameter. Without parameter, you won't be able to come to a conclusion. That is why challenge is given. What Andraj is telling is substance deficiency syndrome. Any woman has to go through that. Unless it goes into the glucose, so she takes off the glucose to the fetus, blood sugar comes down. Now Sunil wants to join with me again. I think I covered that question. Anything else? Anybody want to? Tell me. Mike.
Tell me.
Dr. Subhash is there. Give the phone there.
So, undergraduate student of Dr. Seshaiah at Kilpack Medical College. Sir, the working place where they do a challenge test with the 50 grams glucose. What is your opinion about that, sir?
No, it is given up all over the world. Please, it is given up all over the world.
Like urine sugar test.
It is not accept. Please, Subhashini, it is not followed. Even Americans don't follow that. Fellows who told 50 gram have given it up. So why should we take up a test which is become obsolete? 70 gram?
Still there.
Let them do it.
No. To change that only this discussion.
This conference is meant for only to change your ideas, not 50 gram. If you do 50 gram, you have to do again GDT.
Yeah. So that only 75 grams single dose, single test.
Thank you, sir.
I mean, what you say, Dr. Seshaiah, makes a lot of sense. Earlier on, even for non-diabetic, normal adults, ADA was insisting on fasting blood sugar to diagnose diabetes. There was no emphasis on postprandial glucose at all. Now the wheel has turned, now everybody is talking about postprandial glucose. Postprandial glucose after like you are giving a challenge test. So it does make sense in gestational diabetes also, instead of taking a fasting, to have a challenge and doing irrespective of the meal. I think that's an important point. And now I think we have come back to it. Of course, I want to know the status of HbA1c. Does it have any role at all? Even the patient can afford it. Affordability is a problem, yes. But HbA1c in a patient who is already known diabetic becomes pregnant, does it have any value at all?
It is there, but one thing is the value must be, we have done that study also, normal pregnancy A1C is 5.3. Anything more than 6, you have to suspect she must be having. But only thing is, that's only suspicion, but still you need glucose value to confirm whether she is a GDM or not. That way it's necessary. And again, as I correctly said, this very important point, in Asian Indians, not only in Asian, South Asians, including in Bangkok, Malaysia, everywhere, most of the people do not have fasting blood sugar high, and everybody will have 2 kg going up. That is because by virtue of insulin resistance, Asian Indians are supposed to more insulin resistance, so their postprandial goes up compared to fasting. And then again, the best value to do, as correctly said, is 2 hour postprandial is the best to diagnose, not the fasting at all. Fasting is always confusion. It may not give a correct value or confirmatory value, convincing value. So it is better to do. In our population, we have found out of 100 people with diagnosed GDM by 2 or 70 gram value 140, only 25% cross 92. That means if I gone only by 92 fasting, 76% would have missed diagnosis of GDM, which is not the correct thing to do in our population. That is why we are insisting on doing challenge test. We won't do the glucose challenge test with 70 grams. Someone from there.
Then if there is a non-pregnant level, we do the first time screening, or straight away we screening the pregnant people, because the prevalence of diabetic in general population is around 10 to 20%. The late marriage is common. So first first time we will do HbA1c or RBC, then if negative, go the challenge test, or straight away we do the challenge test. We will at least inadvertently some injury to the patient because we missed we pick up the glucose tolerance in high level, we wait for the 1 or 2 more weeks for treatment. So first initially we do, I think probably we do HbA1c and RBC. If it's the negative level, then we do the challenge test. What is the best way, sir?
See, actually no, it is ideal to have a pre-pregnancy counseling and rule out diabetes, then they can become pregnant. But that is
first
one
time
thing.
Pregnancy
Okay.
in GDM clinic, all pregnant women only coming.
Okay, no, you said no before pregnancy, because the incidence of diabetes is high. So you said, so it is ideal to have a pre-pregnancy counseling, and if they are negative during the pregnancy in the first trimester, you have to do the screening by means of the DIPSI test. The challenge you have to give, and you have to rule out a GDM.
If facility is available for A1C, you do. A1C facility is not available everywhere.
Why don't we have a fasting and a postprandial? If something is abnormal, then go for a challenge test. Suppose he does a postprandial test. If that itself shows above the range, why do you need a challenge test?
Not necessary.
Not necessary. Yeah. I think that answers partly your question also.
And one more important thing is about HbA1c.
Normal postprandial blood sugar level does not rule out GDM. That you have to remember. When it is raised, without any doubt, if it is raised,
madam,
then it's
without
okay.
knowing
Then
whether
no.
he had a diabetic or non-diabetic, suppose inadvertently we push the glucose tolerance, people are asking. So initially we will do fasting or PP. If suppose the HbA1c within normal level.
If you say PP, it's okay, but PP
Because
should
of
be definitely raised.
prevalence of
range.
diabetes in late marriage, the diabetes itself is common in pregnant women.
Okay.
So whether we had a diabetic or then only we do the challenge test.
Yes, Dr. Muhasuddin, you are right. If you can do a postprandial test, if it is high, you can make a diagnosis of diabetes. And if your value comes as unequivocal or below, then you do a challenge test. Agreed.
I feel that's the only thing which one very important about HbA1c for non-pregnant state we have a diagnostic criteria which is more than 5.7 is IGT, and WHO say anything above anything which is GDM in IGT in pregnancy is GDM. So but unfortunately one very important which data has come which shows that pregnancy is a hemolytic state where your HbA1c may not be very much valid for diagnosis, and that's why no one is what Professor Seshaiah has given an indication that it cannot be used as diagnostic. It can be used as a prognostic value investigation, that for the first time when patient comes to you, get the GCT done, or if that gentleman wants to just do random, someone has already sent with the postprandial blood sugar of 180 and 200, you need not challenge them, it's just diagnose them and get HbA1c done so that you have an average value of at least 2 months, and then you can have a prognostic, some discussions on that. That's about this. And sorry? Other area. Yeah. I feel we have some other area to discuss.
There's I read 2 important message. That Dr. What is his name? Mahesh, Muhasuddin, yeah. I believe in democracy. Your choice policy. But it should be different policy. So if you want to do something which you think is correct, may be correct, but when you go and tell the third party this is what it is, somebody must think, no, I agree, disagree. One should not have in the mind disagreement. It should be agreement. See, that is why we are telling, why when you go to the child is taken to the school, they have the test. It is a written test. So you are sure what the child is written, you give the admission. So anything you must do must be definite and concrete. Otherwise, you will not, first suppose the doctor tells she is GDM. I say no GDM. How do you confirm it? So let us follow, okay, I followed the same criteria. This is what? So that none of us will disagree. So that is where we need some amount of uniformity and conformity for us to follow.
Sir, for diagnosis, we are using a challenge test. But for the follow-up, we are having a same fasting and
correct. See, now even that we are given up. If if you read the state health society recommendation, where they're all members, state health society, once they make diagnosis 140 milligram, you just give them meal plan. What I wrote in that, if you find blood sugar 120 with the postprandial, never do fasting because it's impossible for fasting to go up more than 90. Physiologically, if a person has a 120 or 125, impossible for it. Only when you start insulin, suppose meal plan phase, then you have to do the fasting. Otherwise, you have to adjust dose of insulin. Meal plan, it is not necessary. You just save the blood test.
Other than first trimester, we can make it as a first antenatal visit is the best.
That's okay. That's okay. They understood. That's true. But in our country, it's always better to at least whether you must go on telling obstetric colleagues, please start doing it in the first time itself. Even some of the obstetricians refer at 6th week itself. The reason being, after 6th week, whatever you do, nothing, all change has occurred. So if you ask me, first 6th week itself, you must do the test. If you miss the bus, at least by 12th week. So Rao is telling you, you're getting late. Now anyway, any other question? I think we'll skip a treatment. Any other doubt, any other question you'd like to raise?
So this we have, treatment.
Treatment I will not touch because it is individualized. The meal is already told, meal plan is the best for 2 weeks. If the meal plan fails, you can start insulin. And I wish USV, somebody Farida sitting there, please give them all medicine update. That is right up as their guidelines of Indian guidelines. All the members who are here, see that, take their name, all the members, please circulate medicine update guidelines. They're very, very clear about this. I have said, I know whether read it or not, please follow the January. It's very crystal clear what should do and what should not do, what should follow. Last question, please.
Sir, is there any role of estimating, checking the ferritin for maintenance of the GDM? Usually, periodically, we check A1C and all. But ferritin estimation, does it have any role?
See, there's a short-term indication of the glucose protein A, glucose albumin. It is good. But I don't know. I have no idea at all. Please, I'm not expert in that. If you answer for the question, please. You have got some idea, please tell that idea. Please.
Sir, for short-term estimation, they do in pregnancy. Ferritin. Oh, fructosamine. Sorry, fructosamine. We used to do in VHS.
We are doing that also, but it's
a lot of material.
As a matter, we can do that. You can do that.
Anemia is supposed to predispose to GDM. I thought he is asking in that.
So, there are no other question. I thank you very much, my panelists, and the audience
Sir,
interaction.
Sir, treatment, I want to ask you, Lantus can be given in the pregnant woman?
No. See, this is a big question. It's difficult to answer now, not yet approved, so we leave it like that.
So what about the metformin? A lot of obstetricians are giving metformin till the last stage.
You have permission to discuss? Metformin, see, one thing all of us should remember. Any drug you want to give, without obstetrician permission, don't start. If anything goes with pregnancy, she will put you into problem. I'm just like Anjalakshi.
No, my question.
So, you must ask your question to Anjalakshi, madam, can I start metformin because it has been accepted. One. Second thing, very well you can start people with the PCOD. Because that is one indication, no dispute. Otherwise, you must be, because government of India is still not yet approved this drug, some drugs. Insulin is definitely can use it. Glamid we use, but we are not able to recommend now, because again not done by the FDA. Our FDA has not given clearance. So metformin only indication for the state boldly can start with the PCOD. Now she can comment on this.
So, say actually when you start metformin for a PCO people with insulin resistance, you can continue throughout pregnancy to the maximum up to 34 weeks. But as a primary drug for gestational diabetes, it is not approved. But you can add on this metformin when the insulin resistance is very high and they require very high level of insulin. For example, I will tell you, when I was working in the Department of Diabetology, I have seen a patient, 9th pregnancy with no live child. She was a type 2 diabetic, became pregnant. She required 300 units of insulin per day. So we all, this was about 20 years before. We sat together and we added metformin to that patient. The insulin recommend did not raise further. Okay, so it can be added whenever there is insulin recommend is more. That's all. So as a primary drug, you cannot start the drug. Yes, sir?
The dosage is 500 milligrams twice daily or
3 times a day.
3 times a day along with the insulin.
As a primary drug, it is not recommended. India, in our place, it's not approved. Okay. So only for the PCOD, you can start metformin.
Sir, last question for Dr. Seshaiah. Sir, a lot of people are using Lantus. Why it's not be used? I want to clear.
I have no experience. That's why I can't tell.
No, nobody used it. Lantus for non-pregnant people, not for pregnant people.
Pregnancy,
during pregnancy, there is no study. It is not recommended.
But no
studies are coming up now, actually.
But recent times, people started using Lantus.
No. If somebody is using wrong.
See, very recently, only European. Very recent. Okay. See.
In Chennai, nobody is using, but in others.
I feel let us close this chapter here. One very important message to you. Up till now, till 2011, only NPH was to be used and was approved. But 2011, we have got some approval, European approval for Levemir. So now Levemir can be used. Glargine, we have papers available which shows its safety, but no global organization has yet approved Glargine for its use in pregnancy. This is clear. Aspart, Lispro is allowed, is used. Glulysin yet not approved. So amongst all analogs, Glulysin and Glargine should not be used. Other 3 can be used. Is that clear? I feel one should not have any confusion.
See, now what I suggest, if anybody tells you like that, simple question, yes sir, I agree with you. Could you show me your original work? See, something you must do, you have so many population, you can start doing the work, but you must get the approval from the ethical committee. Ethical committee doesn't give approval, you can't do that also. So once the doctor who told you, then Pari was telling, you should ask him, where have you used, how many people you used, what was the outcome, who gave permission, then... No, that's why, see, we should not talk and go away like that. Everything must have evidence. Without evidence, nobody should talk in a forum like this. See, you are asked such an intelligent question, I am very happy. Something we don't even think about that. So we are making you think what you should do. So in that being this type of against audience, one has to be very careful making some comment. So unless you got evidence, I don't think so. Anyway, I am happy to complete this session now. Very happy news. 2 things happened. Government of India Ministry of Health has approved the single step procedure. Second, World Health Organization has also approved single step procedure. So I was telling somebody, I think my job is over, I want to retire from DDF. So I must take some other step. So what do you want 30 years? Now we have seen that what should be done for the public. I think somebody must give retirement pay. Thank you very much. Thank you very much. Association must pay, isn't it?
Association.
Yeah, thanks a lot. Thanks Sunil, thank Anand, thank Anjali, thank Panisulam. Want to add anything more?
No, I want to thank Dr. Vijay Kumar for having arranged this session. Thank you, Vijay Kumar.
Thank you, Vijay.
Thank you.
Thank you.